Hello and welcome to our presentation regarding Joan, who has recently suffered a lateral ankle sprain. My name is Ryan, and along with Gemma, Robert, Benjamin and John, we make up the team of podiatrists at Running Cheetah Podiatry. Today, we will be discussing and exploring the different musculoskeletal imaging modalities that will best help us in the diagnosis of Joan's injury sustained from her lateral ankle sprain. As a team working together in our own private practice that specialises in sports injuries, we plan to discuss the evidence pertaining to each modality and what each technique will provide us. From there, we will be able to develop a diagnostic algorithm to best evaluate Joan's foot pain. Joan is a very active individual who plays footy, cricket, basketball and tennis. Joan presents to our clinic with pain around the styloid process of her right foot after suffering a lateral ankle sprain. After questioning Joan as to the nature of the injury she sustained and performing multiple muscle and biomechanical assessments of her feet, we arrived at two differential diagnoses. We suspect Joan has suffered either a fifth metatarsal avulsion fracture or peroneus brevis insertion tendinopathy. We arrived at these two diagnoses as we could localise Joan's pain to the area at her styloid process. Upon palpation of her peroneus brevis, pain was reproduced, particularly at its insertion at the base of the fifth metatarsal. As clinicians, we understand that an adductor moment across the relatively fixed fifth metatarsal base, characteristic of a lateral ankle sprain, can cause an acute avulsion fracture at the base of the fifth metatarsal. We also know that such a sprain, where the bulk of the weight sustained through the sprain is seen through the midfoot, can also result in peroneal insertion tendinopathy. Given the mechanism of injury to Joan and her presenting complaints, musculoskeletal imaging will need to be conducted to confirm a diagnosis, to move forward with an appropriate treatment method. My colleagues and I will discuss the different modalities and make a decision on which will be the most appropriate for diagnosing Joan's injury. We will do this with a holistic mindset, keeping in mind that other pathologies such as painful os peroneus syndrome, stress fracture of the fifth metatarsal or cuboid, as well as others, may in fact be the cause of Joan's lateral foot pain.
What you see now is the diagnostic algorithm we have designed specific to Joan's case. You can see that after taking into consideration presenting complaints, social and medical history, result from visual and physical assessment of her feet, as well as her mechanism of injury, we arrive at our two differential diagnoses. Once we have our two differential diagnoses, we have to elect an imaging technique that would be most appropriate for narrowing down our two diagnoses. As you can see on the flow chart, all imaging techniques could be used to detect a peroneal brevis insertion tendinopathy or a fifth metatarsal avulsion fracture. Because of this, we have to do further research into the specificity, reliability, and sensitivity of each modality to help us choose which techniques will best diagnose Joan's pathology.
Martin? The first imaging modality that we will consider is X-ray imaging. Firstly, X-ray imaging is a form of radiation that can penetrate through solid objects according to their level of density to capture an image. X-rays are commonly used for the identification of bone fractures, the assessment of healing, arthritis, deformed bones, and localized bone pain. According to Rankin 2009, X-rays are the initial imaging modality of choice for numerous foot and ankle disorders, as they are available readily and provide sufficient detail of bones. Specifically, X-rays are often initially taken to rule out any bone or physical injury. X-rays are particularly important in the identification of avulsion fractures, bone and plantar fascia evaluations, as well as assessment of acute osseous injuries. However, they have limited significance in the analysis of complex bone anatomy and chronic soft tissue disorders in which the soft tissue itself is poorly detailed. Although X-rays are a common imaging modality regarding the diagnosis of bone breakages compared to other imaging practices, they have considerable disadvantages. X-rays are highly sensitive depending on the amount of exposure to radiation, whereas MRIs have enhanced sensitivity for bone damage without the consequences of exposing a patient to harmful radiation and iodinated contrast agents. X-rays also have the possibility of causing cellular damage within the body due to their harmful ionizing radiation, which can consequently lead to cancer. Lastly, fractions are often diagnosed on X-rays and radiographs, however quite slowly, so an MRI is often necessary to formulate the diagnosis. For our case study on Joan, we would recommend an alternative imaging modality to help diagnose her condition.
Musculoskeletal ultrasound uses sound waves to generate images to view soft tissue structures and fluid collection. If the tendon is monitored by thickening or heteroechogenicity, it is abnormal looking. Normal tendon looks like tubular pattern of parallel hyperechoic lines in the longitudinal plane and hypoechoic round to ovoid in the transverse plane and may be monitored tendon sheath as hypoechoic rim. There is no radiation risk associated and is cost effective. In Joanne's case, ultrasound isn't the first choice imaging modality as it is stayed quite variable, which might be associated with the suboptimal training and competency of a few ultrasound providers. Unlike MRI, ultrasound is not standardized, so therefore obtaining high quality and informative images involves considerable expertise in image acquisition, a skill that takes many years. Ultrasound is one of the few imaging modalities where the practitioner needs to be present, unlike MRI, which provide automated, very rapid, standardized scans without practitioner present. Ultrasounds have revealed that they are useful in the diagnosis of fractures, and the accuracy for detecting the fractures in patients who had them was very high, with a specificity of 96.4 and a sensitivity of 87.3. Ultrasound has a high sensitivity, accuracy and positive predictive value for the diagnosis of peroneal tendon injuries. A study by Grant and colleagues noted that ultrasounds diagnose tendon tears with a sensitivity of 100%, a specificity of 85%, an accuracy of 90%, and the positive predictive value of the test was 80%. In addition, ultrasounds have the ability to detect peroneal tendon subluxations. So for Joanne's case, we would recommend an alternative imaging modality to help diagnose her condition.
The modality that we decided would be best in regards to Joanne's case is MRI. Let's have a look at the factors why we made that choice. First of all, both MRI and ultrasound are considered to have a major role when it comes down to evaluation of muscle pathology. But MRI has a key advantage in assessing muscle conditions due to its ability to visualize structures in all planes. In addition, it can allow visualization in a single sequence, an extremely difficult thing to achieve with ultrasound. When compared to X-ray, it provides a wider range of sequences. For example, it will examine all body structures such as muscle, tendon, ligament, vessel, bones in just one scan. That would rule out any provisional diagnostic and specifically point out the cause of the pain, which would then help to treat the patient at a faster rate. When it comes to sensitivity, MRI has devolved into imaging modality selection of the food, as its sensitivity in supporting the discovery of soft tissue and osseous abnormalities. Two studies concluded that MRI has high sensitivity from 83.9% to 92% when evaluating peroneal tendinopathy, and patients with lateral ankle sprain were from 57% to 100%. Having a high sensitivity and specificity does indicate that it will be reliable in detecting abnormalities. As for safety issues, there are almost none, as MRI does not use radiation. The only downside is that it is costly, and Joanne may be subject to co-payment and deductibles as it is not fully covered by Medicare. In case of claustrophobia, we would refer her to an open MRI where only her foot and ankle will be inside the imaging tube.
In terms of result, on the MRI, we expect to find the accumulation of fluid in her peroneal tendon sheath, which would indicate peroneal tendonitis. Multiple factors such as tight calf muscles, inappropriate training, poor biomechanics, and the weakness of her peroneal longus muscles might have contributed to her conditions. As for her treatment, initially it will include rest, immobilization, anti-inflammatory medication, and protected ambulation. In case of her symptoms does not improve and become chronic, surgical decompression is often offered, and most of patients end up doing on us in case their conditions become complex. That would be the end of our presentation. Thank you.